The final diagnostics that we're going to be looking at are angiograms and renal scans. So a renal angiogram is the study of the renal blood supply. So even though it is going to highlight the collecting system too, because it really has no choice, this is going to do a better job of highlighting the kidney itself. So you're going to be able to see the blood supply going into the kidney, and since the kidney is so well perfused, it's going to light the kidney up. It's going to help us to diagnose any renal artery stenosis, any aneurysms, vascular tumors. It can even show us areas where there isn't as much circulation, areas that are ischemic or even infarcted. Now, the other diagnostics that we're going to look at are renal scans. Renal scans are like, they're just CT scans, but they're of the kidney, so we call them a renal scan. A CT scan, remember, kind of looks at the kidney in slices. So if you took that kidney and you sliced it in 1 centimeter slices and you looked at each slice individually, that's what it's going to show you. So you're going to basically see a cross section of the kidney. They look a little weird when you're doing it that way, but I'll show you kind of a normal one, and then I'll show you all the ones that aren't normal, okay? But it's going to also help detect renal infarction. It also identifies renal disease, and oh, by the way, it does a really good job of showing us renal tumors. So if you've got a cancer or a renal tumor or even a very large cyst, but it's going to do a really good job of showing that. Okay, so this is a renal angiogram, and you can see that although it is showing you the collecting system, because you can see the renal pelvis, you can really see the artery turning into the arteriole, coming into the kidney, and you can see how well the cortex of the kidney is perfused. But wait, look at this area of the kidney. So the entire upper pole of the kidney, I mean, it's getting perfusion. You can see some urine collecting there, but is it getting the perfusion that the bottom is getting? Of course, your answer to that better be no. More than likely, the reason for that is if you follow this back, I'm going to circle it. Do you see the area that I'm circling? Do you see how this is kind of, pretty fat, and then there's this stricture right there? Well, that stricture may be preventing blood flow from going to the upper part of the kidney. So for this kidney, more than likely what they're going to do is they'll go in through the femoral artery down low in the leg, of course, or in the groin, and they'll pass a stent, and they'll actually use a stent to try to open that up. And then, of course, they can kind of watch as they do that. If suddenly the upper part of this kidney is better perfused, then they know they have fixed the problem. Now, these are renal scans or CT scans, and they're showing us a lot more than the kidneys. I get that. They are showing us, a lot of good stuff in the abdomen, but we're focusing on what they're showing us with the kidneys in this unit. So if you look here at the one on the upper left, these kidneys are beautiful. They are, they're not exactly the same shape because one is actually lower than the other, so you're not seeing picture perfect mirror images, but they look perfectly normal. They are supposed to look a little bit lighter in color in the center because that's where the collecting system would be, whereas this outer portion where the cortex is, that they would look a little darker. So those look perfectly wonderful. Now let's come here. This kidney looks good. That's a good looking kidney. It's still got kind of that area in the center where you can see it's a collecting system. But what do we have here? This kidney is completely misshapen. Here is the kidney, okay? Here is the tumor. And as you can see, that tumor is roughly the same size as that kidney. That's one of the bad parts about kidney tumors and kidney cancer. It is so well concealed that usually by the time we find it, they're pretty good sized, okay? So this here would be a renal tumor. So I have 2 more scans here for you. Now this one, there's actually quite a few abnormalities in this one, but I want to focus on the kidney. So once again, here is what is left of the normal kidney tissue, and here is a tumor. And I hope what you're seeing here is this tumor is actually growing outside of the fibrous capsule and some of these may be mets from that. You notice this side looks completely different than this side. Okay, now look down here, same thing. This kidney looking pretty decent, pretty normal. This kidney, not so much. And oh, look at that. And there's no question that that is solid. I mean, nobody's going to look at that and think that's a cyst. That is solid tumor material, and you know, the likelihood that that is cancer is actually pretty high. And now we're just going to kind of get into some odds and ends here. Other studies that we can do, urodynamics are a big deal in urology right now, especially with the baby boomer population, definitely going kind of over that 60 and into the 70-year-old mark for sure. Urodynamic studies are done to assess innervation of the bladder and incontinence issues. Also some other voiding problems, but it's used a lot for incontinence. Well, you'll hear me say this many times, but incontinence is common, but it is not normal. That is not something that we should go, oh, well, that's normal, and we shouldn't even try to do anything about it. When you have as many people as we have right now who are at the age where incontinence is a common problem, it kind of breeds more studying of the issue to see if it can be solved. So there's a lot of new information coming out on urodynamics. Urodynamics is a part of urology that's very much growing because of that ability to figure out, you know, ways to help people maintain their continence. Another study is called a cystogram. Now, a cystogram is basically an x-ray of the bladder, but we insert dye into the bladder from the bottom, so we use a cystoscope to do that, or you can use a catheter. You can do it either way, but what you're looking for is if the dye in the bladder refluxes up into the ureters. That's not normal. The ureters should peristalse in a way that urine should only come down. But if the dye is allowed to ascend, if it's allowed to go up, then that's telling us that the ureteral orifices are not doing a very good job of closing that off, kind of in between when it's squirting the urine into the bladder. And what that means is if the patient gets a urinary tract infections, it allows those UTIs to ascend and get into the pelvis of the kidney. And so if you've got somebody with chronic pyelonephritis who also has chronic bladder infections, then when you do the cystogram, you can easily tell that, you know, that's what's happening. It can also help us diagnose neurogenic bladders. Neurogenic bladders are bladders that are not innervated in a proper way, so when they go to void, they don't void appropriately. And then it can also help us identify fistulas as well. Now, this is a test that's got a really long name, and so we've, of course, given it a nickname. A cystometrogram is a test where the bladder is filled with fluid. We just usually use normal saline or sterile water. We fill the bladder with fluid until the patient is like, okay, I need to go now. We want them to get to the point where they don't feel like they could hold it anymore. We measure that amount of fluid that we put in. Then, if we usually do this with a catheter, so then we remove the catheter, and then we allow the patient to void naturally. So they void out as much as they can void, and then we recatheterize the patient for residual. We want to see how well their bladder actually emptied when it was filled to capacity, and then we want to see, you know, what it left behind. It measures bladder tone and the ability to adequately empty the bladder. But since we fill the bladder and then pull the catheter, we call this a fill pull. So if you hear that terminology, yes, it is a cystometrogram, but we very rarely ever say that. We just say we performed a fill pull, you know, and this is what happened. An open renal biopsy is the most invasive diagnostic test that we've talked about yet. Because to do this, we're going to make an actual incision. We're going to make an incision just like we would if we were doing a nephrectomy. So it'll be thoracoabdominally, kind of over the side, down at the base of the rib cage. When we get down to the kidney, what we're going to do is take a small wedge of that kidney. Now we're going to try to take it from the area that has the suspicious tissue, because that's why we would be doing this to begin with. Either a renal scan or some other test showed us that there was an area of maybe what we think is a tumor. We're not sure if it's a tumor or a cyst, but we're trying to take a sample of it to send to pathology. So the pathologist is actually going to look at this, probably do a frozen section so we get information back pretty quickly. Most of the time, if we're doing this, we've already got consent from the patient that if it comes back as cancer, since we're already open, we just go ahead and remove the kidney at that point. If it doesn't come back cancer, if it's just a cyst or something else, then we will, close them up. But you can't make a definitive diagnosis without a tissue sampling. So you can't make a definitive diagnosis just by looking at a CT scan. You can tell what's pretty suspicious, but you can't make a diagnosis. When you finish with this surgery, one of the most important things to do is get adequate hemostasis, because when you're taking a chunk out of the kidney, you are literally taking you're cutting into several of those nephrons, which we all know, that's circulation. You've got afferent arterioles going into every one of those nephrons. It's going to bleed. So you need to make sure you get adequate hemostasis. We'll use some surgical fiber that's treated with thromboplastin and try to use those things to stop the bleeding. But we're going to continue to watch the bleeding even after the patient is closed and in the recovery and on the floor by doing something called a 4-bottle routine, or it's also called serial urine specimens. What we do is when the patient voids, we measure it like we normally would, but we take a small kind of splash of that urine and we put it into a clear urine specimen cup. We have 4 of those cups. They're literally labeled 1, 2, 3, 4. The second time they void, we put a little splash in the second cup. The third time, a splash in the third cup. What we're looking at is that urine looking better, or is it not getting any better at all? If it's looking better, there's going to be less and less hematuria in there as the day goes on. So it might start off looking like cherry red Kool-Aid, okay? Hopefully it will get to where it's much lighter in color, or like pink, and then eventually that pink will almost turn to a tea color. Tea color suggests old blood rather than fresh blood. So that's what we're looking at with this 4-bottle routine. You always keep 1 cup empty so you know where you've left off, and you just keep rotating the cups until you get it down to where it's pretty well clear urine, and then you can stop doing the serial urine specimens. An open renal biopsy is not the only surgical type of diagnostic test. Technically, if we do a cystoscopy or a ureteroscopy, those are surgical in nature. They require anesthetic. Usually they are usually done in the operating room. Now, a cysto can be done in the office if they use a flexible cystoscope, but a lot of times if they're looking to potentially not only diagnose but treat, a flexible cystoscope is not going to be adequate for that. So a cystoscopy is direct visualization of the urethra, bladder, and the ureteral orifices as they open into the bladder. A ureteroscopy is taking that a little bit higher up, so obviously you need a much longer scope and a skinnier scope, but it's going to directly visualize the inside of the ureters, and then it has the capability, because it is long enough, to go all the way up to the renal pelvis and possibly, even visualize some of the individual calyces. The thing about these diagnostic tests is they are diagnostic. They're going to help us with the diagnosis. We're going to be able to see what's going on and make a definitive diagnosis. But they can also be used in some cases for treatment. For instance, if we go into the bladder and we find a bladder tumor, we not only can diagnose the bladder tumor, but at that moment, then we can treat it by resecting the bladder tumor if it's small and it's superficial, okay? If we go into the ureter and we see a stone, not only have we diagnosed them with the ureteral stone, but we can use a basket extractor or use laser and use that ureteroscope to treat the stone. So these are for diagnosis, but they're also for treatment. The other diagnostic, I've already mentioned to you, the retrograde pyelogram. You can use a cystoscope to put a catheter into the ureter, right into the ureteral orifice, and inject that dye, just like I showed you in the X-ray portion. Okay. But you can also, do other things with the cystoscope. You can do a bladder biopsy. You can fulgurate. If something is bleeding, okay, if they have some part of the bladder that's bleeding, you not only diagnose the source of the bleeding of the bladder, but you can use a little device that provides some electrocautery and actually fulgurates or cauterizes that bleeder. So that's another option. You don't think a whole lot about foreign bodies in the bladder, but I'm just telling you, that happens. And so we can also do some foreign body removal with the cystoscope. With the ureteroscope, we can, primarily diagnose things and treat ureteral stones. We can also place stents, so that if we need to keep the ureter open, that stent will help us maintain the patency of that ureter.